A quiet revolution is approaching the world of healthcare financing, one in which aging itself is increasingly viewed not as an inevitable decline, but as a modifiable risk factor, worthy of proactive intervention. As longevity science matures and therapies such as senolytics, cellular rejuvenation, and biomarker-based diagnostics demonstrate consistent, cost-effective disease prevention, we are likely to see a tectonic shift in how health insurers and national care systems approach aging. Where anti-aging treatments are today largely the domain of private payers and high-income consumers, tomorrow's insurance models may include structured reimbursement for longevity-enhancing interventions, fundamentally redefining the economics of aging. This shift will be driven by both data and pragmatism. Age-related diseases, heart disease, cancer, neurodegeneration, osteoporosis, diabetes, account for the vast majority of healthcare costs in developed nations. Treating these diseases at advanced stages is extraordinarily expensive, often involving hospitalization, long-term care, and complex drug regimens. If aging interventions like senolytics or stem cell-based tissue repair can delay or prevent the onset of these chronic conditions by even a few years, the long-term cost savings could be enormous. This is the same logic that led insurers to eventually cover statins, smoking cessation programs, and more recently obesity medications like GLP-1 agonists, not out of idealism, but because prevention proved cheaper than treatment. In the near future, longevity trials will begin delivering this kind of cost-saving evidence. If, for instance, a single annual course of a senolytic drug reduces hospital admissions for cardiovascular disease or prevents frailty-related falls in seniors, insurers will have a strong incentive to cover that therapy. Likewise, if personalized biomarker panels reliably predict early biological aging, insurers may offer free or subsidized screening as part of regular checkups, knowing that identifying high-risk individuals early can allow preemptive intervention before expensive disease develops. Already, precedent is forming. Some forward-looking private insurers are experimenting with wearables and preventive health incentives, discounts for exercise, nutrition coaching, or tracking sleep and stress. The next wave will likely extend this model to aging biomarkers, perhaps offering premium reductions for clients who demonstrate a slower pace of biological aging through regular testing of DNA methylation, inflammatory markers, or metabolic flexibility. An aging rate dashboard could become as common in a health insurance portal as BMI or cholesterol once were. In parallel, corporate health plans may lead the way in offering longevity benefits to employees, viewing them not only as cost-saving but productivity-enhancing. Large tech and finance firms, already on the leading edge of wellness perks, may soon offer on-site senolytic infusions, subsidized NAD+ therapies, or AI-guided aging management programs, not merely as luxuries, but as strategic investments in reducing sick leave, burnout, and premature retirement. Over time, as evidence builds, more conservative industries and public employers will follow. Public health systems, Medicare, the NHS, or Japan's universal care infrastructure will initially move cautiously, demanding high levels of proof for safety, efficacy, and cost-effectiveness. But once landmark trials demonstrate that targeted aging interventions delay frailty, dementia, or hospitalization in older adults, public coverage will likely expand. The rollout may begin with high-risk populations, seniors with early signs of immune senescence or inflammation, before broadening to midlife preventive programs. A possible structure for this evolution is the annual longevity visit, covered much like an annual physical or cancer screening today. Patients would receive a biological age assessment, an AI-generated lifestyle and supplement plan, and, if warranted, a covered pharmacological intervention such as senolytics, mTOR modulators, or stem cell rejuvenation therapies. If the individual adheres to recommendations and demonstrates a slowed aging trajectory, insurers may reward compliance with lower premiums, reduced deductibles, or extended coverage windows into advanced age. But this future will not arrive without significant policy, ethical, and clinical hurdles. First, the medical establishment must agree on definitions. What constitutes a treatable aging process? Is aging a disease, a syndrome, or a risk factor? Regulatory clarity will be needed before payers can confidently reimburse these therapies. Second, insurers will demand real-world outcomes, not just biomarker shifts, meaning longevity trials must track not only cellular aging, but hard endpoints like hospitalizations, quality-adjusted life years, QALYs, and survival. Third, equity will become a key concern. To avoid widening health disparities, coverage must extend to underserved populations, and longevity benefits must not become a new tool of exclusion by socioeconomic status. Despite these challenges, the long-term logic is compelling. As aging becomes measurable and modifiable, the incentive to intervene early, before disease strikes, will become financially irresistible for insurers. Longevity therapies will move from boutique clinics to primary care. Anti-aging plans will sit alongside cholesterol management and cancer screening, and a new model of insurance will emerge, one that doesn't merely pay for sickness, but actively rewards the slowing of time itself. In this world, aging won't just be something we endure. It will be something we manage with coverage.